Testing. Okay, we're going to get started so that our speaker can have ample time to talk. Just a couple of housekeeping announcements. There's a sign-in sheet for faculty and staff. Faculty and staff can sign in. Dr. Greaves' students, there's a sign-in sheet for you as well. If you're in Dr. Cameron's class, when you fill out the program evaluation form, write Dr. Cameron's class at the top of it, and that. Oh, and make sure you put your name on it so that you get credit. Also, you all have a program evaluation form, and you should also have a handout for the talk. Please fill out the program evaluation form because it helps Dr. Sullivan and others in the faculty development program get the best speakers for you, those that you'll enjoy the most. So I'd like to introduce today our speaker who will be talking about fibromyalgia, a topic that's of extreme clinical importance and has a fairly complex history and diagnosis, which you'll learn about. And to talk about this is Dr. Michael Schneider, who was in chiropractic practice for over 25 years before getting his PhD at University of Pittsburgh and subsequently getting an NIH grant to further develop his research career. And since then, he's gotten additional research grants. And so is one of the most highly funded researchers in the field of complementary and alternative medicine. And he's a great guy and is collaborating with some of us here at National. So please give a warm welcome to Dr. Michael Schneider.
Yeah, I turned it off. Okay. Everybody hear me okay? I can hear myself. So we have a short period of time here, about 50 minutes, for a topic that typically when I teach a seminar, it's a 12 or 16-hour weekend course. So in 50 minutes, right, probably 30, 40 minutes to leave you some questions. I'm going to breeze through this real quickly. I'll mention that I published a couple of articles here that we're going to be referring to. Most recently, a systematic review of all CAM therapies for fibromyalgia, which we published a couple of years ago. We've written about 3 or 4 articles about the paradigm that I'm going to speak about here today. So don't worry about it. If I breeze through it real quickly and you want to read about this, you can just pick up the articles and read them yourself. And I have my email address on here too. Is the mouse showing when I do this? Yeah. Okay, it's easier than a laser pointer. So if anybody wants to contact me by email, feel free to. There might be a lag time when you get a response, but I will always respond to you. So this thing of fibromyalgia syndrome has always been interesting to me as a clinician because I saw these patients in practice. And how many of you have seen a patient like this? Right? This is their pain. This is an actual pain diagram from a patient that came to Frederick Wolf as a rheumatologist. Subsequently, this is a typical, what I call classic fibromyalgia patient. They hurt everywhere. So where's the pain? Where's the pain generator? What's causing this? Well, a lot of people would presume, primary care doctors say, well, that's myofascial pain. No, it's not. Myofascial pain is regional pain. This is widespread. So what do you think causes something like this? Well, early on, before there was an F word, I like to call it that, the fibromyalgia is the F word. I'm from New Jersey, it has a different meaning there. But before there was the diagnostic term fibromyalgia, rheumatologists thought, well, this looks like rheumatoid arthritis. This looks like ankylosing spondylitis. It looks like Lyme disease. And that's why the rheumatologists got into the game early on, because of this pattern of looking like it was a systemic inflammatory disorder. So what do we know about the pain generator? Well, many presume it's coming from the muscles. Well, it's not. Because if that's true, a lot of these patients would respond to myofascial techniques. They don't. They hate deep pressure. They don't respond real well. The classic fibromyalgia patient. When somebody does respond well to myofascial techniques, guess what? They don't got fibromyalgia. They got myofascial pain. They're 2 different things. And if there was inflammation of the muscles, wouldn't you expect patients to do well with anti-inflammatory drugs? They don't. The patient with classic fibromyalgia syndrome does not respond to NSAIDs. They don't respond to prednisone dose packs. A rheumatoid patient does, but a fibromyalgia patient doesn't. So it's not inflammatory. A lot of work's been done with muscle biopsy, fascial biopsy. All these tissues have been biopsied over the years, and there's been nothing pathognomonic of fibromyalgia. They have not been able to find any peripheral soft tissue abnormality, right? So what's the conclusion of all this research? Well, that fibromyalgia is not a type of muscle pain. It's not a form of muscle dysfunction. And guess what? That's why manual therapy and even these nutritional therapies, they're not going to cure fibromyalgia because it's not a problem in the peripheral tissues, as we'll get into in a moment. So there's many myths. If we're going to talk about fibromyalgia syndrome, we need to dispel some myths. The first one, which is probably the most common, is that the tender points, which are found in fibromyalgia, are nothing more than trigger points, myofascial trigger points. Well, it's not true. They're different. In fact, Simons and Trelvell 10, 20 years ago said we have to start differentiating tender points from trigger points. They're not the same thing. Because if it were true that tender points were trigger points, we could rub them out. Right? We could do myofascial techniques and get rid of this pain. We can't. Now, some patients who've been diagnosed with fibromyalgia improve with manual therapy. But most of them will literally never come back to your practice if you use deep pressure point techniques. They cannot tolerate it. So I actually wrote a paper about this, believe it or not, 1995. I can't believe it, how long ago that was. Talking about the need for clarity in terminology here. So if you want to get that paper, go ahead and read it. That's myth number one. What's myth number two? Well, fibromyalgia is just some type of soft tissue inflammation. Right? It's not rheumatoid, it's not gout, but it's some type of unknown inflammatory disorder. Well, if that's true, as I said before, anti-inflammatory medications would help these patients. They don't. There's been numerous randomized trials comparing all sorts of anti-inflammatories with placebo. They're no better, including prednisone and corticosteroids are no better than placebo. Well, how well does cortisone work for a rheumatoid patient? Or a patient with gout? If you have true inflammation, those drugs will give significant relief. They also give significant side effects. But they don't help in fibromyalgia. Right? So none of the randomized trials have shown any appreciable relief with anti-inflammatories. So it's not a soft tissue inflammation. In addition, seborrheic, C-reactive protein, all the biomarkers of inflammation, they're normal in patients with fibromyalgia syndrome. So how could it be an inflammatory disorder if the drugs don't work and there's no biochemical marker of inflammation in their body? And yet, I bet you if I went around the Chicago area today, I would find patients diagnosed with fibromyalgia by a primary care physician who are given a prescription for an anti-inflammatory drug. Even though all the systematic reviews and guidelines say do not do that, it's still being done in general practice. What's another myth? This is a big one in chiropractic and naturopathy. It's a form of metabolic syndrome. And there's still people around the country teaching this in naturopathic and functional medicine circles, that fibromyalgia is a form of it's a metabolic dysfunction. And if we get the person's body chemistry right, we can get rid of this pain. Well, if that were true, then these nutritional and dietary interventions would really help most patients with fibromyalgia. And they do in some people, but not all. In fact, I would say in a majority of patients with the classic presentation where they ache all over, they don't do well with these nutritional therapies. There's something else going on. It's not simply metabolic dysfunction. And I challenge people about this all the time in the functional medicine world. What's unique? What's uniquely different metabolically about these patients? Well, depends who you listen to, right? Some say, well, it's a magnesium deficiency. All right. I've heard other people say it's intestinal dysbiosis. I've heard all sorts of vitamin D deficiency. Well, if it's all these different things, then those are all different disorders, right? They're not one disorder, fibromyalgia syndrome. My guess is that they mimic, and I'll get to this. I think there's an element of truth to this, but that's not a classic fibromyalgia patient. This is a person that's achy all over, that's metabolically distressed. Yeah, you can help somebody who's sort of achy, has flu-like kind of symptoms, if you will, but they don't have classic fibromyalgia. So the other one is that we know there's a 10-to-1 ratio female to male with fibromyalgia. Fibromyalgia is predominantly a female disorder. So one would think, besides the obvious anatomical differences between males and females, right, that there's hormonal differences. And so a lot of the early research went into looking at estrogen and progesterone levels. There's no correlation between estrogen and progesterone and fibromyalgia symptoms. Postmenopausal women, premenopausal women, women who are on hormone replacement therapy, there's no correlation between their pain symptoms. The only hormone that's been shown to be associated with widespread pain and fatigue is thyroid hormone level, right? So my challenge for that is, okay, if somebody has hypothyroidism and they ache all over, do they have fibromyalgia or do they have hypothyroidism? You see? So there are some people around the country saying, well, fibromyalgia is nothing more than misdiagnosed or subclinical hypothyroidism. Well, I would argue no. If you find a person who has subclinical hypothyroidism, that's the diagnosis. You don't need the diagnosis fibromyalgia then. Another myth. Fibromyalgia is nothing more than a somatization disorder, right? So somebody who has anxiety or depression, they feel their pain in their body, and it's a psychiatric illness. And again, there might be a little bit of truth to this, but it's not completely true because I'm sure that everybody in this room knows somebody who has anxiety attacks or has been clinically depressed, right? The incidence of this is huge, right? Everybody knows somebody who's clinically depressed. Now, if you think of that person, you don't have to raise your hand, but if you think of a family member or friend who's been depressed and treated for depression, do they exhibit this widespread pain all over their body where they can't be touched and they can't function and they're on disability? No. Not everybody who's clinically depressed or anxious has this thing called fibromyalgia. However, if you look at the people who are disabled by fibromyalgia, the comorbidity of anxiety and depression is very high. But it doesn't mean that they're equivalent disorders. Because there are many patients with psychological disorders that don't have this widespread pain. But here's the interesting thing. The drugs that help patients with fibromyalgia are antidepressant drugs. They seem to have an effect on pain that's independent from mood. You get that? So a person can have widespread pain, you give them a very low-dose antidepressant where they still feel depressed, but they don't have as much pain anymore. So there's an independent, these drugs do something to the central nervous system different than mood. And we'll talk about that a little bit. Paradoxically, I just told you that people with anxiety and depression don't all have fibromyalgia, but invariably, if somebody has fibromyalgia, they do have a comorbid anxiety and depression. And that's not a contradiction. Right? Just like people with chronic low back pain, right, will develop depression. There's a higher incidence of depression in chronic low back pain patients than there is in the general population. That doesn't mean that depression leads to chronic low back pain. It could be the other way around. So are these all myths or partial truths? I think all these myths are based on some truth, right? Everybody who came up with one of those myths saw that in their practice, right? So people who treat metabolically, like naturopathic model, they saw people get better. Some people who do myofascial techniques saw some of these patients get better. Some people who did thyroid replacement therapy saw patients get better. But the problem came in is when these some cases became all cases, right? So I have an individual success here or there, and then I extrapolate that and say, I found the magic bullet. That's where the problem comes in, right? We all have successes, but to say that all cases of fibromyalgia are caused by one thing, that one cause, one cure, attitude has plagued that profession for a while, huh? Since the BJ days. Right? So maybe these myths are partial truths, and maybe the problem is the way that we're looking at fibromyalgia, right? So how do we reconcile these myths with what we know from the scientific literature? Well, my conclusion is we need a new paradigm. It's not just my conclusion. A lot of people believe this now. The old paradigm is that fibromyalgia is this single entity, this disease, this syndrome, right, with what's the best protocol for this? In a lot of ways, it's like back pain, right? What's the best treatment for mechanical back pain? Well, maybe we shouldn't be talking about mechanical back pain, right? Maybe we should be talking about the subsets of back pain that respond to different treatments. Same thing with fibromyalgia. a newer paradigm might look at this label, this term of fibromyalgia, as being divided into subsets, right? And that each subset has a different treatment protocol. So maybe one subset is metabolic problems, right? And those people with metabolic problems that have been misdiagnosed with fibromyalgia will do well with a metabolic program. Maybe some people actually have myofascial pain that's been misdiagnosed as fibromyalgia, and they will respond to myofascial techniques. Maybe there are some people with hypothyroidism that have been mislabeled as having fibromyalgia, and they need thyroid replacement therapy, right? And so I think if we start breaking down to subsets, that makes more sense. So remember, a syndrome means we don't know what's causing it, in plain English, right? It's a cluster of symptoms versus a disease which is characterized by at least two of these three things. There has to be a recognized etiological agent, there has to be an identifiable set of signs and symptoms, and consistent anatomical alterations. Why does fibromyalgia syndrome not fit this disease? Because we don't know what the cause is. Yeah, there's a set of signs and symptoms, but there aren't consistent anatomical alterations. So it's an S word, right? So we got the F word and the S word. And syndrome is the S word. Right? If you don't know what something is, then you call it a syndrome, right? And isn't that what medicine likes to do? It's idiopathic. I love that. Idiopathic. It just means we don't know what's causing it. Why can't you just say you don't know what's causing it? Why do you have to make up words? One of my favorites is irritable bowel syndrome. What's irritable bowel syndrome? It means that you have, pain and nobody's been able to figure it out. So is irritable bowel syndrome a single syndrome? Well, a lot of chiropractors and naturopaths would say no. All of these things I'm going to throw here on the right and others can cause what a medical doctor would say is irritable bowel syndrome. Right? We have patients that go on antibiotics, it messes up their colon, and they develop irritable bowel syndrome. That's intestinal dysbiosis. That's a disease. That's not a syndrome. There are patients that are walking around with lactose intolerance, they don't know it. Right? Or they have a food allergy, and their stomach cramps up, and they think they have this thing, irritable bowel syndrome, and they have a food allergy. But nobody's figured it out yet, right? So there's many reasons for irritable bowel. So if irritable bowel can be divided into subsets, what about fibromyalgia? Is it a single syndrome? Or is it just a label that's put on a cluster of things? Right? What will those cluster of things be? Well, we just mentioned a few of them. Anybody have a patient with seronegative rheumatoid arthritis? Yeah, there are people that have rheumatoid, their knuckles are swollen, their elbows are swollen, and when you do the rheumatoid latex fixation test, it's negative. It's not 100%. So does that person not have rheumatoid because the blood test didn't show it? Their SED rate will be elevated, right? But there are people with rheumatological disorders that defy the testing. There are many patients with Lyme disease who haven't been tested are being told they have fibromyalgia. This is a big one, myofascial pain being misdiagnosed as fibromyalgia. Right? Yeah, there are metabolic syndromes, like somebody's really low at vitamin D, what are they going to feel? They ache all over and they have fatigue. So on and on and on. Drugs can do this. Statins can cause fibromyalgia syndrome, where the person aches all over and feels like they have the flu from statin myopathy. Right? And on and on and on. So the widespread nature of fibromyalgia pain, which looks like this, led to, in 1990, is where this F word got started. So in 1990, the American College of Rheumatology had a consensus conference where they came up with these two criteria. By consensus, not necessarily by research, by consensus they said there's going to be two things that define a diagnosis of fibromyalgia. The patient has to have a history of chronic widespread pain. And they define widespread as bilateral, above and below the waist, and axial skeleton. The torso has to be involved. All they're really doing is essentially describing this kind of a patient, right? It's bilateral, it's above and below the waist, right? And their axial skeleton is involved. That's all this criterion number one is talking about, right? And then they made up these 18 sites, When I say made up, they are made up. They're not necessarily anything important. They just decided by consensus that these 9 areas, 18 is 9 bilateral areas, that they're areas that are easy to palpate on patients. That's where these 18 points came from. They're just simple areas that are superficial and easy to palpate. And they defined tenderness as less than 4 kilograms of pressure. You know where that number came from? One of the researchers at that conference had some preliminary data showing that if you press hard enough to blanch your thumb, that's 4 kilograms of pressure. So in clinical practice, it was easy to go in and press until your thumbnail would blanch, and if the patient said it hurt, that was a positive tender point. That's why they picked 4 kilograms. Very arbitrary, right? These are very arbitrary kind of criteria. That's it. So how many of your patients might fit this category and have other disorders, right? It's kind of a problem right from the start. The term itself was developed at a pure consensus, and so we have some issues with this. All right, so these are the original 18 points. They're arbitrary. They mean nothing. What's really interesting is after they defined these 18 points, a priori, researchers went on to biopsy these areas to see what was different about them. And of course, they found nothing. But it's sort of like the dog chasing its tail, right? Like, why would you expect these areas to show anything anatomically when you just pick them out of thin air anyway, right? It's kind of weird. Made for a lot of research dollars going into universities' research departments. I can say that now. I'm starting to learn the research game. I mean, seriously, some people just do research to get the money. Not that they're really trying to find anything. It's terrible. Some of us have higher standards, right, Greg? That stuff does go on. So 20 years later, fast forward 20 years later, just a couple years ago, the ACR had another consensus conference, and they came up with a new criteria. So now they're saying it's not that much different. They're saying, again, the patient has to have widespread pain. I'll explain what this thing means in a minute. And they use a form. So now the new criteria have completely eliminated physical examination. Can you believe this? When I read this, I'm like, oh no, I can't believe they're doing this. So they eliminated physical exam, and now there's a checklist. The patient checks off enough of these areas, that's the widespread pain index. And then they have another index, which is called the Symptom Severity Scale, and I'll show you that in a minute. So they have some numbers for these. So that's number one. They have to have a certain number on the widespread index scale and a certain number on the symptom severity scale. Number two, the symptoms have to have been present for at least 3 months. There's your chronic. And the patient does not have a disorder that would otherwise explain the pain. That number 3 gets missed all the time. Right? So if a patient has, I've seen this, patient has rheumatoid arthritis complicated by secondary fibromyalgia. What does that mean? They have rheumatoid. That explains their pain. Right? Or they have Lyme disease complicated by secondary fibromyalgia. It seems redundant, doesn't it? I mean, if they have a disorder that explains the widespread pain, what do you need this secondary fibromyalgia thing for? There actually might be some rationale for that, which I'll explain in a moment. But these are the new criteria. So what's the widespread pain index look like? These are the actual questions. There's 19 areas now. All right, so the patient is given a checklist, and they just check off how many of these areas have been painful in the past week. No physical exam. So you know why they came up with this? So that you could diagnose fibromyalgia in epidemiological ways. Right? You could send out surveys. I could put the survey online and go into the Chicago area and poll people to see what the incidence of fibromyalgia is here without doing a physical exam. It's problematic, in my opinion, because, just because somebody has pain in a few of these areas, does it mean that they really have widespread pain according to what we would consider fibromyalgia? And even more importantly, how tender are they? Right? Because if you've seen fibromyalgia patients in practice, the classic ones, you can hardly touch them. That's the defining characteristic, is that extreme tenderness. How do you get that from a questionnaire? That's my commentary. So that's the widespread pain index. How many things you've checked off, right? The other scale that they give them are 4 questions. The symptom severity scale has 4 questions. 1 is about fatigue. 1's about waking unrefreshed. 1 is about cognitive symptoms. So they ask them, in the past week, tell me what level of fatigue you've experienced. Excuse me. Same thing with waking unrefreshed. Rate that from 0 to 3. Cognitive symptoms, 0 to 3. And then, this was the original question. In general, the physician is supposed to fill this one out. Indicate whether the patient's had none, few, or moderate, or a great deal of symptoms. This one made me laugh. So I challenge you not to laugh when you see this next slide. So here's what they listed as the somatic symptoms. You think I'm joking, right? This is right out of the article. I mean, this is ridiculous, isn't it? I mean, what isn't on that list? So, obviously, I wasn't the only person who was outraged about this because they went in and modified a year later. There was such an outcry about this because the doctors are saying, well, what's a few? What's a great deal? I mean, this is crazy. Give me a number. Is there supposed to be 3 of those? Is it 10 of them? What's going on here? So they finally relented and they changed it to basically say, on 0 to 3, report whether or not the patient has headache, cramps in their abdomen, or depression. So now this question was replaced with no symptoms, headache, irritable bowel symptoms, and depression. So if they had all 3 of those, they get a 3. If they had any one of those 3, they get a 1. So now that's been modified. And I can give you the references for this stuff if you want to read it. So now a patient can have widespread pain if they can have a diagnosis of fibromyalgia if they have widespread pain for 2 months, 3 months. Look at the numbers here. Their total score has to be from 0 to 31. So their widespread pain range can be from 0, if they checked off all 19, and they checked off all 3s, that would be a 31, right? If from the symptom severity scale, if let's say they check off 10, right? They'd only have to have a few of these. Because, let me show you now. So the patient can have a 7 or more on the widespread index and a symptom severity scale of 5 or more. Or if the symptom scale is 9, they could have as low as 3. You could have as low as 3 of these areas and meet the definition of fibromyalgia. I don't know about you, but I'm getting really nervous about this. I'm thinking, what's going to happen to the incidence of fibromyalgia around the country now? Yeah, because it's going to be easier to diagnose this because more and more people will meet the definition. And not to be a conspiracy theory person here, but it just means that more Lyrica prescriptions will get written. That's what it means to me. This is ridiculous in my opinion. I can't believe that. So, Frederick Wolf was one of the first people on this ACR committee. He wrote an article. This is the title of it. Can you read that? Fibromyalgia-ness. This is not a joke. This is a peer-reviewed journal in Arthritis and Rheumatism. And what he said is that there's a fibromyalgia-ness continuum in many diseases. And he says, and he's one of the lead people in the American College of Rheumatology, he says fibromyalgia is not a separate disorder. It's not a thing in and of itself. What it describes is people that are 1 or 2 standard deviations from the mean. What do I mean by that? So he has symptom intensity scores on almost 24,000 rheumatoid patients. This came from a national database. If you take the average rheumatoid patient, they're scoring about here. Then they looked at the patients who met the criteria of having fibromyalgia syndrome. Their mean scores were 7.25. They're out here. So what he's saying is that of all the rheumatoid patients that are out there, Some of them go on to develop this really widespread pain and tenderness that we call fibromyalgia. He has subsequently said that this could be true of cancer patients. It can be true of Lyme disease patients. It can be true of patients with chronic back pain. That there's a certain subset on the tail end who start off having a regional pain disorder and it blossoms into something bigger. And that's what we're calling fibromyalgia. But it's not really a separate disorder. It's a central sensitization syndrome. So essentially, people with chronic pain syndromes can develop a central sensitization disorder. Just happens to have the F word. So in a sense, what he's saying is if you look at the nociceptive continuum, right, we have normal sensation, let's say normal nociceptive pain. But when somebody has a chronic condition, they can develop hyperalgesia. It could get to allodynia, right, which is where you feel pain to a non-painful stimulus, which is always abnormal. These are the patients who have what we call fibromyalgia syndrome, classic fibromyalgia syndrome. They've developed allodynia, widespread allodynia, or widespread hyperalgesia. So if we can determine the cause of the patient's widespread pain and fatigue, then we don't need the F word anymore, do we? We just call it what it is. So this is one of the articles that we published some years ago about my theory is that of all the patients you're going to see with widespread pain and fatigue as a chiropractor or a naturopath or even as a primary care physician, there's going to be a minority. I'm making these numbers up. These aren't based on data. This is just clinical observation. About 1 in 10 of these patients, they're going to fit this classic fibromyalgia pattern where they really do have widespread pain. They really are tender to the touch. They have multiple problems, right? They have headaches. They have weird Raynaud's type symptoms. They have irritable bowel syndrome. They have a lot of stuff going on besides just their widespread pain and fatigue. All right? That's a minority of them. The majority of cases, again, this is my opinion, and from clinical practice, they have other problems that could explain their widespread pain that have a very definitive treatment. In a sense, they have what I would call pseudo-fibromyalgia. They don't really fit the classic presentation, and they're misdiagnosed cases. The classic patient, I believe, and my co-authors do, that it's truly a psychosomatic disorder. Now, that word has very negative connotations in America, but it shouldn't, right? That when people have such intense psychological stress, to the point of like a post-traumatic stress disorder, they have somatic manifestations of that. That's different than a somatization disorder, right? A somatization disorder, the person really is crazy. They have a psychiatric disorder where they feel pain in their body that isn't there. That's really, really abnormal. The classic fibromyalgia patients have somatic complaints and somatic problems that are very real, but they are triggered by psychosomatic stress. What do I mean by really very real? We'll talk about that in a moment. But the classic patient has this widespread allodynia. They have a sleep disorder. Almost all these patients with classic fibromyalgia do not sleep through the night. They don't fall into stage 4 sleep. It sounds like hypervigilance in the post-traumatic stress literature. These patients are fatigued, they have pronounced fatigue and exercise intolerance. There's been some studies that show that these classic patients have abnormalities of cortisol and other circulating adrenal hormones, as well as some other biomarkers. They complain of a cognitive dysfunction, which is probably secondary to the sleep disorder. And they have various sympathetic and parasympathetic things going on. They don't just ache all over. They have irritable bladder. They have irritable bowel. They have migraines. They get weird paresthesias. They have multiple chemical allergies. They're sensitive to sound. They're sensitive to light. So they have a central sensitization syndrome. So there's a lot of literature showing a much higher rate of sexual, physical, and emotional abuse in patients with fibromyalgia than the general population. That's there in the literature. What's really interesting is that functional MRI studies now show that the patients who meet this classic presentation, if you put them in an fMRI unit looking at their brain and apply a non-noxious stimulus, that their limbic structures light up. They shouldn't. They go into their brain is going into a fight or flight response to a non-noxious stimulus. That's not normal. And they're not faking that. Their nervous system is overreacting, if you will, to a mechanical stimulus. We also know that antidepressant medications reduce the pain of fibromyalgia. And what's really interesting is that very recently, in the past few years, we're seeing genetic markers in these patients. Patients who have this widespread pain and tenderness, they have some polymorphisms on genes for neurotransmitters. So this might be there might be a genetic predisposition for patients to develop what we call fibromyalgia syndrome. So it's like a genotype that won't become a phenotype, if you will, unless there's something that stresses the system. All right? And so a patient who's genetically predisposed, they get a botched back surgery, have 2 or 3 of them, and start dealing with chronic pain for a couple of years. That triggers a change in their nervous system such that they now express this genetic abnormality, and they truly start aching all over their body, and they develop a central sensitization syndrome. And if they truly have central sensitization, we would expect more than just the widespread pain, right? We would expect them to have multiple symptoms, which they do. So the question is there a latent fibromyalgia genotype? And this is like the most current debated literature right now. So, bottom line is, if you're one of these classic fibromyalgia patients, if it is a psychosomatic type disorder by the true definition, then they need both treatments, right? They need some somatic treatment, right? And they need some psychological treatment. What about all the other cases you see in your practice? Well, we think that there's 3 subcategories of patients who are misdiagnosed. Metabolic, medical, musculoskeletal. Let me explain each one. And again, this is just our theory. So there's many diseases that cause fatigue, exercise intolerance, widespread soft tissue pain, right? Many, many diseases. There's just a couple. I've seen all these in practice over the years, where people have these conditions and are being told they have fibromyalgia. They don't have true central sensitization disorder. Right? Probably the most glaring is hypothyroidism. There are a lot of people with hypothyroidism that have not been diagnosed and are told they have fibromyalgia. Why? Because it's easier just to tell them they have fibromyalgia than to start doing some blood tests and working them up and seeing what's wrong with them. And God forbid they should be sort of a borderline case, right? Where the TSH is kind of normal, and their T3 and T4 is sort of borderline, but they have all the symptoms, right? Those kind of patients are very often told they have fibromyalgia, and they're put on an antidepressant drug, when what they really need is thyroid hormone. It's very common. I've had every one of these. This is terrible when patients have cancer, and they're told they have fibromyalgia. I had a neighbor who has multiple myeloma who was told he had fibromyalgia until they found the multiple myeloma, right? I've had several patients over the years, including a good friend of mine who's a nurse, who was having weird, tingling, migrating tingling and numbness in her body. And you love this one. She goes to primary care doc, says, I'm not feeling right. Well, what's wrong? She goes, I don't know. I just don't feel myself. I'm getting weird stuff going on. What do you mean? And I'm getting this tingling in my hand and sometimes in my elbow. It's not consistent. And he's, well, just point to where it hurts. Well, I'm trying to tell you, I can't really point to where it hurts. It's really hard to explain this and everything. And he said, well, if you're not going to tell me where your problem is, I can't really help you. Well, I'm trying to tell you. Well, what are you getting angry at me for? What are you yelling at me for? Well, because you're not really listening to me. Well, are you having a problem with your marriage? What do you mean by my marriage? I'm trying to tell you about my... And he started saying that she was depressed and that she was, started going down that route, which was weird, isn't it? only to find out that she had multiple sclerosis. It took about 2 years as the symptoms progressed and progressed and progressed and then she had an MRI. So sometimes fibromyalgia is misdiagnosis. I think it's going to get worse as time goes by here as we enter into healthcare and we have more people screening patients with chronic pain who don't know what they're doing. So these are the kind of things that need to be done first, right? Wouldn't you think that anybody with widespread pain and fatigue for which there's no answer, shouldn't people get some of these things? But what we're seeing in primary care medicine is they're not doing any lab testing, right? You go in and you have some diffuse pain through your body, you're not getting anything done. And I think that's where the misdiagnosis comes in, right? Just basic primary care medicine is not being practiced the way it used to. And it's only getting worse, right? Because as we go to national health reform now, another topic, it's only going to get worse. There's going to be more pressure not to do tests, unnecessary tests. Yeah, we do a lot of unnecessary testing, but sometimes it is necessary. And especially in fibromyalgia, you're not supposed to give the diagnosis until you've ruled out other disorders, right? It's not being done. So these all have to be negative before you would ever consider a diagnosis of fibromyalgia. So what about the metabolic functional thing, which is really big in chiropractic and naturopathy? Well, so chiropractors, naturopaths, other people in healthcare, holistic healthcare have often said that dysfunction precedes pathology, right? It's more challenging to diagnose that, right? So, I mean, a good example would be, I like this term, sublaboratory hypothyroidism, not subclinical. The person has the clinical symptoms, right? But the laboratory tests don't necessarily show it. Many of you know these things. I don't have to go into it. But a person doesn't have, as opposed to these things, which are true disease pathology states that get missed, the metabolic things are more functional changes. So people who practice functional medicine, for lack of a better term, may find some of these things in their patients that get misdiagnosed as fibromyalgia. Right? A big one's statin myopathy, isn't it? I find this really interesting in this particular study. They talk about the literature with statins. About 1 out of every 10 patients who gets a statin is going to have symptoms from them. I mean, it's pretty common to have widespread pain. So this is a case of 45 patients on biopsy who have confirmed myopathy. Right? CK is considered pathognomonic. It's normal in a third of those patients. These people have confirmed myopathy, and the blood test is normal in a third of them. The liver enzymes, which primary care docs do routinely, to see if it's okay to keep giving people statins, in almost all these 45 patients, they didn't have any elevation of their liver enzymes. And they have myopathy. So what about the average patient who's on Lipitor or Mevacor, one of these drugs, and they're getting their liver tests done, they're normal. Oh, everything's okay. It doesn't mean it's okay. They could be having liver damage occurring, but it's not significant enough to show on the blood test yet. And now they got widespread pain, and they come in and docs say, oh, you've developed fibromyalgia. Here's Lyrica or here's an antidepressant. Well, wait a second. It's a secondary to the statins. That happens. Right? Vitamin D is another real big one. Right? It's rampant in our society. It can give weird, achy kind of symptoms. So how many people are being told they have fibromyalgia just have vitamin D deficiencies? Right? The most common symptom of low vitamin D is diffuse musculoskeletal pain. Last but not least, we have myofascial problems or musculoskeletal disorders that are misdiagnosed. So there are many muscular problems, joint problems, disc problems that get misdiagnosed as fibromyalgia. Why? Mainly because in primary care medicine, they don't know how to do musculoskeletal diagnosis. Right? I know for a fact at University of Pittsburgh, we have a medical school. I speak with medical students all the time. They do not have even one course in musculoskeletal diagnosis in 4 years of medical school. They don't have one course in musculoskeletal. And you know what? They don't want to do that. They do internal medicine. So why is it a surprise that the last statistic I saw is that if you went to a primary care clinic and polled people in the waiting room, that about a quarter of the patients, about 25% of the patients seeing a primary care doctor, there for a musculoskeletal complaint. Right? And they're going to see somebody who's not trained in musculoskeletal diagnosis to manage their case. What an opportunity for chiropractors. What an opportunity. Musculoskeletal triage. So you know what? The MDs are not going to pick this up. We need doctors of musculoskeletal medicine to pick up these musculoskeletal disorders. We need doctors of functional medicine, if you will, to pick up the functional problems. Maybe that's, I'm just defining a role for chiropractic and naturopathy in the United States, right? And it's because of this misdiagnosis that a lot of people are told they have fibromyalgia and they really don't. They have something else. This is really bad. So this is one study I've seen where they looked at the misdiagnosis rate. So this is at a major medical facility where people are being sent supposedly with fibromyalgia for treatment. And the researchers basically just did a tender point exam on them to see if they fit the 1990 criteria. They can only confirm that a third of the patients who are being treated for their fibromyalgia in a specialty clinic, only a third of them met the ACR criteria for fibromyalgia. And this is their verbatim conclusion from this research study. There's a disturbing inaccuracy, right, in the diagnosis of fibromyalgia, right? This finding may help explain the current high reported fibromyalgia rates, should caution physicians to consider other diagnostic possibilities when addressing. You know what they're saying here, basically? Put out your hand. What the is wrong with you? I mean, how can you have only a third of these people? What do the other two-thirds have? Do they have hypothyroidism? Do they have myofascial pain? Do they have intestinal dysbiosis? I mean, what do they have that's causing their widespread symptoms? And they're treating them with antidepressant drugs, putting them on physical therapy programs, and giving them psychological counseling. Now, that's appropriate for the classic fibromyalgia patient, but less than a third have the classic presentation. So the conclusions here, classic fibromyalgia is a term I use. It's not a distinct disease. It's a syndrome characterized by these signs: widespread pain, poor sleep, multiple somatic complaints, severe fatigue and cognitive dysfunction, this tenderness, true tenderness all over. That's classic fibromyalgia. And it's rare in clinical practice. It's more likely that you're going to see patients who have misdiagnosed pathology, who have some kind of metabolic dysfunction that's mimicking as fibromyalgia, or they just have simple garden variety musculoskeletal complaints that have been misdiagnosed as fibromyalgia. And that if we match what the patient has to the treatment, I think we can get better clinical outcomes. And I think it's a mistake to throw all of these people into research studies and to see what's the best treatment for all these people, because they're not all the same. That's basically my theory in a nutshell. I'm going to finish up real quickly here. These come from a paper. You have the citation at the bottom that I wrote a couple years ago, where it talks about the 4 subsets and kind of basically outlines what each one looks like. And it's followed by a diagnostic algorithm. This talks you through the examination of a patient to figure out what they have. So this is a full page in the article, so if you get it, this is a very nice resource. I've actually sent this to primary care physicians. When I used to want to see patients, now that I don't want to see patients anymore, I don't send this out. But I've had many primary care physicians say to me, this is the best thing that they've ever seen. This makes so much sense to them. It's so logical, because they don't know what to do. Not that it's so great, but compared to what they do, it's rocket science. So these are the 2 key references I would recommend that you take a look at. This is not in press anymore. It's actually published. These 2 papers, I think, will give you really good information about fibromyalgia. And again, here's my email if you have more questions. So I want to end there because I think we're about done, aren't we?
Yes, we have time for just a couple of questions. So first, let's thank Dr. Schneider. And are there any questions? Yes.
I have a question. Is there any new standards right now? Okay.
They would hear you in Florida.
Oh, okay, sorry.
Are you loud enough to be heard in Florida?
No. Is there any new standards right now for the not the checklist for fibromyalgia, but like we're using old standards from 1990. Is there any way of now tacking on new research and applying that research onto current standards now? Like, I mean,
Yeah, well, the new thing are these two forms are being used. So now that 19 area checklist and that symptom intensity scale, those are actual forms that people are using in practice now. And there's a fibromyalgia impact questionnaire, which would be like the oswestry, if you will, for fibromyalgia people.
Plus his algorithm on his papers might be a good thing to look at.
My grandmother was diagnosed with fibromyalgia about 20 years ago. And obviously listening to this makes me feel like, what if she was misdiagnosed or something? And I'm constantly, just worrying about her. She's always in pain, and she's done everything non-naturally, just very allopathically. And what would you suggest, like, for me as her granddaughter, like, recommending for her to see if she really has it, one, and, like, two, how do you think is the right way to treat?
So maybe you want to talk to me after class, because that's going to take...
Okay.
I can give you some suggestions, but it's going to take a few minutes to do that.
Okay.
But grab me outside the room, and I'll be happy to talk to you about that.
Okay.
The first thing I will say is that in any case, when I get a question like that, is the diagnosis correct? That's the key. Does she really have this widespread pain and fibromyalgia? Does she have something else? That's a really important point.
Okay, I think this is a good place to stop. Thank you very much, Dr.
Okay, thanks.
Hey, Mikey from Florida. Can you hear me? You turned it off? Oh, all right. Forget about it. You can't hear me, so we'll see you. I can't hear you. You're gone now.
you hear me now,
So, oh, yeah.
So you got to teach them about the metabolic stuff.
But I had a question, though. If the hey, Greg, how are you? So, based upon the fact that it can be multiple different diagnoses driving the widespread pain, it seems inappropriate to use the term central sensitization syndromes, because then that excludes all the other metabolic possibilities. So I'm just curious where you are with that and where you see things currently with that use of that term that just seems to be too pigeonholing of the condition.
So, yeah, I think when people who exhibit the classic symptoms have a central sensitization disorder. But I think the people right? But I think that some people who have these metabolic disorders don't really have a central sensitization disorder.
Yeah, because central sensitization disorder is so general. If you're talking about the psychological component, that would make more sense. But independent of those patients, which would be far fewer than the classic, as you said, the true fibromyalgia patients are low, so the number of people who actually have central sensitization disorders are probably really few and far between because they don't satisfy the proper criteria of
That's correct.
fibromyalgia.
I think they are in a small minority.
Yeah. Okay. Thank you.
See ya.